Okay, so obviously no quiz. Your quizzes from the other day are right there so that you can get them after class. Did we have any questions from yesterday? Or not yesterday, but Tuesday? Really? Why is it staying open? You think? Oh, it's automatic. There we go. All right, so no questions. Well, that's cool. Did we hit this slide? Is this where we're at? No, maybe. Kind of looks like we did this one, right? Red button. Okay. Uh-oh. So now it gets a little bit more real here. Okay. So does intramembranous even show up on your guys' thing? Maybe just a little bit? Okay. So there's two types of ossification, how bones are formed. When we're talking about ossification, how do we make bones? One's intramembranous and one's endochondral. Intramembranous makes the flat bones. It's the one I'm least concerned about. So what I want you to know about intramembranous is that it makes flat bones. So flat bones in the skull, like the parietal bone, the sternum, the scapula. That's how these are made. I can't believe I have much on your packet about it. Well, we're not going to do all that. All right, so know that it makes the flat bones. Ignore that. All right, how's that? So, don't say that I wasn't kind, that I just took off a big chunk of stuff. All right? Now, here's where you say, well, you're not so kind, because we're going to have to learn how we do endochondral ossification. Okay? And it's fairly involved, but try to, whatever you can, visualize it, picture it, whatever, and it's not too bad. So, basically, when we see chondral, we know it has something to do with cartilage, right? So, endochondral ossification is forming bones from a cartilage model, okay? Meaning they started off as cartilage. We kind of saw that on that picture of the fetal skeleton. You know, the red were bones, and then everything that was kind of like that you didn't see a bone where you knew there should be one, that was cartilage. Cartilage doesn't show up on x-rays, okay? So, endochondral ossification, these things started off as cartilage. So what happened was the mesenchyme, which was embryonic connective tissue, developed into hyaline cartilage in the shape or the form of the early bones. Okay? Hyaline cartilage had a perichondrium that wrapped around it, which we already know is a little bit of what? Dense, irregular connective tissue kind of around the outside. Okay? The perichondrium was initially producing chondrocytes. That shouldn't be a revelation. At this point, it's perichondrium. It's of the chondrium, of the cartilage. What are the cell types of the cartilage? Chondrocytes. So it's producing chondrocytes, okay? And what's going to happen is you've got this, we're going to make it kind of a square bone or a long bone, because this is how long bones develop. And in the center, we have these chondrocytes, okay? These chondrocytes are going to start to multiply, which we have a name for, right? Do we remember what that was beginning with an H? Hyperplasia, okay? So they undergo hyperplasia, and they start to swell and get bigger as well, which we call hypertrophy, okay? So if we had anything, okay, that could expand, and I start to make the things inside of it multiply and swell, what's going to do to the container that it's in? The container is going to have to get bigger, okay? And that's what's happening with this cartilage. That's how the cartilage is growing. The cells multiply and get bigger. And this starts in the center, okay? So if we've got a long bone, this is happening in the center. Out here, we also have chondrocytes, but they're not multiplying yet or swelling yet, okay? It starts here, okay? So that's, if you keep in mind that it's starting in the center, and it's actually going to cause the bone to grow this way, and then eventually after that stops here, the cells on either side of it are going to start to multiply and swell. And then these out here are going to multiply and swell. And you can see how that's going to keep pushing the bone longer and longer and longer. Okay, can you visualize that? Because that's what's going to come up here on this next thing. So if you have a visual, I always feel like that helps me. So the chondrocytes multiply and swell. They line up They kind of get in single file lines almost and form columns. Now, reducing the matrix. We know by now what the matrix is. It's the protein fibers and it's the ground substance. Okay? If I had an aquarium here, all right, and I put, I don't know anything about aquariums, so that's really not a good analogy. But if I had rocks in the bottom of it, and I looked at this aquarium and I said 10% of this aquarium is filled with rocks, the other 90% is water. And water is going to be our matrix. Okay? The rocks are going to be analogous to our cells. If the cells in there, the rocks, got bigger and multiplied, and I was able to come back and look at the aquarium and say, well, now it's 50% rocks. By that happening, I thereby reduced the percentage of water, right? I reduced the matrix. That's what's happening. That's what it's saying there. So less of this cartilage will be matrix now. More will be taken up by the rocks. Does that make sense? Okay. Cool. So the chondrocytes, hyperplasia, hypertrophy, line up in columns. They're reducing the matrix. The matrix around them calcifies. Okay? Now, here's an important concept. It calcified. It becomes calcified cartilage. It doesn't calcify to bone. It's calcified cartilage. And because of this, these cells can't get their nutrients via diffusion. So what happens to cells that don't get their nutrients? They die. Okay? So it cuts them off from their nutrient supply and the cells die. So now we had a single file line, let's say, of chondrocytes. And they died. Now we're going to basically have almost a little tunnel through the bone, right? That was taken up by cells. Now the cells are gone. Now it's empty. Okay? If we have enough of those, that's going to destabilize this cartilage structure. So it's kind of like having a block of cheese. The cheese is fairly stable, but if we put enough holes in it, or we're playing Jenga and we take enough pieces out, now this thing is unstable. Okay? So what's the body going to do about that? The perichondrium will then start to produce some osteoblasts, and they're going to put a collar of bone. They're going to basically put a shell of bone around the outside to help to try to protect it from being so unstable. Okay. Doing okay so far? We have an okay visual in our minds of what's going on in this wacky world of endochondral ossification. So the next thing that's going to happen is blood vessels are going to penetrate, because it's a very thin splint of bone around the outside. It's going to break through that. It's going to enter into the center of the bone, and it's going to dump in blood, stem cells, and fibroblasts. Okay? So, the bone, that vessel is going to penetrate. It's now in the center of the bone. Okay? Because in that bone, all right, these cells started to line up in here, and they died. Okay? So we put a little splint of bone around the outside here to try to stabilize that area. Blood vessels are going to penetrate in here and do what I just said. Dump stem cells, fibroblasts, and blood. Now while that's happening here, out here, these chondrocytes are going to start to do that hyperplasia and hypertrophy. Okay? So keep that in mind. So what can we do with stem cells if we fuse 3 to 50 of them together? We can make osteoclasts. Fibrocytes can become osteoblasts. And the blood, if it's held in there with some reticular fibers, is going to become our marrow cavity in the very dead center. Okay? And we just dump the makings for osteoblasts and clasts. All right? The clasts are going to clean up that calcified cartilage, and the blasts are going to replace it with osseous tissue, right? That's what they do. All right? So we've taken this cartilage, it died, we clean it up and we replace it with bone. And that's happening right here in the center. While over here, we're going to have that hypertrophy and hyperplasia going on. And over here, it's going to be just resting cartilage. Nothing's happening there yet. But this growth here did cause the bone to grow in each direction. Okay.
Why is this happening? Is it because
No. This is just growth. This is just growth. This is a 4-year-old child. Okay? Yeah, no problem. This area becomes the primary ossification center. The center portion of that's the primary marrow cavity. Okay. So the next steps I've already told you, but we'll hit them anyway so you get them in your notes. The fibroblasts become osteoblasts. Osteoblasts do what osteoblasts do. They're going to deposit osteoid tissue, bone. Okay? They're going to produce the collagen fibers. They're going to put calcium phosphate in it. It's going to crystallize to hydroxyapatite. Okay? And this is going to start to form a bony framework of trabeculae in the center of that cartilage model. This follows a wave of cartilage death moving towards each end of the bone. Okay? That's what I'm trying to tell you here. This is going to undergo hypertrophy, hyperplasia, line up in columns, and die. Okay? The osteoblasts in class that were here are going to follow it. Clean it up, change it to bone. Then that happens here. Follow it, change it to bone. So you see how the cartilage is multiplying, growing, and then dying, and the bone's just following it. It's like it's chasing it. Okay? And that transition we have between bone and cartilage, we see that in the bone as that growth plate, or the, what's the other name for it? Epiphyseal plate. Okay? And as long as we see cartilage there, we know the bone hasn't stopped growing. So it's like going to the dog track. They let the rabbit go around the track, the dogs are chasing it. All right? This chase will go on until they catch the rabbit, or the rabbit goes in its little thing, and then they're all confused on where the rabbit goes. Okay? This is going to follow it until it catches it. Once it catches it, now we've reached our full adult height. The bones aren't going to get any longer. Now it's no longer the epiphyseal plate, it's the epiphyseal line, and you'll still see a line. Okay? Stem cells fused together give rise to osteoclasts. They hollow out that marrow cavity, so we have the area for the bone marrow in the central part, and they do this by breaking down the calcified cartilage remnants. Okay. So the perichondrium around the outside here had cells, osteogenic cells that produced the bony collar, and we dumped some on the inside to produce the bone on the inside. So that's the setup we have with the bones, right? We have a connective tissue followed by the osteogenic cells, and then on the inside we're going to have the endosteum, and between it and the bone we're going to have osteogenic cells. Once this perichondrium, this area underneath it here, changes to bone, it's no longer the perichondrium, it's now the periosteum. It's the same stuff, but it's different area over a different thing, so they change the name. Okay? Can we grasp that? All right. So the perichondrium becomes the periosteum. Our metaphysis is this transitional region, the region where we're going from cartilage to bone. Okay. So here's the book's pictures on this. So here we have a cartilage model of a bone. Okay. Here we have in the center, the cells start to undergo hypertrophy and hyperplasia. They multiply. That makes the bone bigger, or the cartilage bigger in size. Okay. They line up. The cartilage around there calcifies, the cells die, the pericardium starts to put a little bone splint around the outside. When they're totally dead in there, the blood vessels will penetrate, dump the what? What are the three things? Stem cells, fibroblasts, and blood. And we can see that this would be a good spot. This will be the marrow cavity. This will be the bone marrow takes place. It's also primary ossification center because this is where we actually start to lay down the bone. So osteoclasts start to hollow that stuff out. Osteoblasts start to lay down the bone here. Now, because the blood vessels penetrated there, they're going to grow this direction in those columns. Remember we had the columns. They're dead, so that's a nice pathway for the bones to go. Or not the bones, the blood vessels to go. And then we'll lay bone down around them. That's how bone's vascular. The blood vessels were there prior to the bone being laid down. Okay? And all this happens going towards each end. So we're going to have cartilage and bone. That's our epiphyseal plate. Okay? There's one other little thing that happens here, and I'll show you in just a second. But how are you doing on just that? If you can visualize it, if you can understand it, always makes it easier to have it stick in your brain so that you can write it down on the essay question on the test. Okay? So, we have a secondary ossification center that forms in the epiphysis near the time of birth. Okay, so let me back this up real quick. So we have to look back at this picture here. This would be the epiphysis, right? This would be the epiphysis. We're going to develop a secondary ossification center. This is the primary ossification center forming the marrow cavity. Secondary one. So it's going to do the exact same thing that was going on here. It's going to start that process here. So we're still going to have bone and cartilage. Bone and cartilage. Okay? So your metaphysis is actually a transition from bone to cartilage, cartilage, bone. Okay? Your growth plate, I should say, is actually two metaphyses. This transitional area when we went from cartilage to bone here, and the transitional area we go from cartilage to bone here. They come right up against each other. So, secondary ossification center forms in the epiphysis near the time of birth. It goes through the same stages of the primary ossification center. So you don't have to tell me what they do because you hopefully already told me prior to this. You're going to tell me that it happens at the epiphysis near the time of birth. The center of the epiphyseal cartilage is turned into spongy bone. Now, the difference being, for the secondary ossification center, is here. So when we start to hollow this out and we start to lay down new bone, okay, we're going to have a transition to cartilage here, cartilage, bone. That's our growth plate. And at some point that's going to close. But out here, we're never going to remove the outer edge of that cartilage. What are we going to leave there instead? The hyaline cartilage. That's how it's got on the ends of the long bones. It was there first and we leave it there. Okay? Does that make sense? Okay. So the hyaline articular cartilage remains on the joint surface. And what we're left with is the epiphyseal plate. Okay? It's that junction of the diaphysis and the epiphysis where we have that transition. It used to be cartilage. We're changing it to bone, and it's just following it. It's the wave of cartilage death being followed by changing it to bone. As it dies off, we replace it with bone. Okay? How's that, work in your brains? Seem all right? Maybe pretty doable if you get a little chance to look it over and study it? Because that's one of the big takeaways from this unit. Okay? Oh. That's what I look like when I take my mask off. I don't even remember what this is, but I know it's a link. But I also know that the damn volume doesn't play with the microphone on. So let's see what comes up here. Oh, it's so much better when we have volume. Sorry. Let's see what they show us here. Looks like a skeleton to me. Shoulder joint. trying to guess at what they're telling us. That one was holding a grenade. Oh, we're going to finally get to the development here at some point. Move it along a little bit. You know, I put it on here for some reason. I don't remember what. All right, show us the osteoblasts. I think this is the fibers, how the fibers get laid down, collagen fibers that we're going to calcify, crystallize. Osteocytes, yeah. Oh, here we go. Keep going. What's this thing right there? Yeah, well, yeah, there'd be an osteocyte in there, right? The central. Well, no, that'd be a central canal. Excuse me. I trusted you. Come on, show us how bone grows. God darn it. Okay. Oh, they use the same pictures. They can't quite be talking through all that. Here's that secondary ossification center. There's the cartilage chondrocytes lining up. Come on, go back to that. Oh, I think they will. I probably have this on, already have it on the site for you guys. So anyway, chondrocytes resting here, they multiplied here, they swelled up, they lined up in columns, they got the matrix around them calcified, cut off from their nutrients, they died. They put a bony collar around the outside to protect it. The blood vessels are going to penetrate it. There we go, bone collar, keep going. Blood vessel penetrates that bony collar, dumps in the fibroblasts, the stem cells, the blood, and you can see out here what's happening on these ends. The chondrocytes are swelling up, multiplying, lining up, because this is their fate just in a little bit. Okay? The blood vessels will then run through those columns up and down, and those will form our what? When they're running parallel to the bone, the blood vessels, they're forming our central canals, right? Setting up our osteons when we lay the bone layers around them. Okay? Near the time of birth, secondary ossification center develops. That growth, that transition's going back towards the diaphysis, and we see the same steps happening. We're going to leave the hyaline cartilage out around this end. Yeah, well, seemed like a good idea at the time. Let's see what this is. I'm almost certain I put these under ancillary videos there. So, chondrocytes multiplying, lining up, dying, reducing the matrix. Blood vessels on the outside are going to penetrate the bony collar that helps protect it. I'll let you guys watch the videos. They're already on there for you. Because that's just without volume is no good. All right, so walk through these. So this is skipping ahead a little bit, but we had the primary ossification center. We had where the calcified cartilage happened around those chondrocytes. They die, all right? They leave this kind of hollowed out area. We put a bony collar because the perichondrium produced what? What cells lay down bone? Osteoblasts. So perichondrium produced some osteoblasts. They made a thin splint around the bone to protect it. Okay. This will also happen at the secondary ossification center at the epiphysis near the time of birth. We have a blood vessel penetrate that bony collar, drops stem cells that become the osteoclasts, fibroblasts that become the osteoblasts, blood that's going to basically be in the marrow cavity. The blood vessels grow up and down the bone in those columns, forming our central canals and later our osteons. Near the time of birth, we get the secondary ossification center that develops. Okay? Those chondrocytes lined up, died. Blood vessels penetrate into there. The blood vessels are going to grow more this way. This transition between bone, cartilage, and bone is our what? Exactly, epiphyseal plate. Okay? So what you really have is this transition from bone to cartilage. That's a metaphysis. This transition from bone to cartilage, that's a metaphysis. Each epiphyseal plate has two metaphyses. Okay? All right, so what is the metaphysis? It's a transitional area from cartilage to bone. You find it in the developing long bones between the epiphysis and the diaphysis, or between the head and the shaft. This endochondral ossification with these metaphyses, with these epiphyseal plates, is how we add length to the bone, otherwise known as interstitial growth. In these developing bones that started off as hyaline cartilage, there's 5 zones at various stages of this development. Okay? And we're going to show you the 5 stages here in just a second. The epiphyseal plate gets smaller and smaller with age because of what's happening is what? Why does it get smaller? The what's catching the what? The bone being laid down is catching up to the cartilage that's dying. Okay? So the bone's being laid down just slightly faster than the cartilage is dying. Okay? So it's like running a race. You guys give me a head start, but all of you are probably faster than I am. So eventually, over some distance, you're going to catch me, because I'm not going to go that far. I'm going to quit at some point.
So this might be jumping ahead just a little bit, but if a fracture occurs between the epiphysis and the diaphysis or upper epiphyseal plate, what happens to the growth?
That's a real problem when that happens. They generally have to reattach that. They have to put some sort of pins in there, but they have to be careful that the pins don't stunt that growth. So what exactly goes on, I can't really tell you, but I know that any fracture through the growth plate is a big deal. Okay? They have to reattach that, but they can't do it like they would normally, where they put pins in and leave them indefinitely. They're going to put them in, try to get some attachment, get the pins out of there, immobilize it so that it can go back to normal. Because if you have a pin in there, and it's, let's say we have a pin in here holding this somehow in here like this, that might slow down the growth on this side, and this side grows, and then you're going to have a bone deformity. And so they're really conscious of not having that happen. And because little kids, their bones really aren't as strong and solid as adults, they have this cartilage in there, this stuff can happen. Okay? So the metaphysis, the 5 regions in this transitional area, what they're really talking about is this cartilage at rest. So if we were looking at this, we're going to have an area here, 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 here. 1, 2, 3, 4, and 5. That's what they're talking about. The first is going to be an area of rest. Nothing's happening. They're calling it the reserve zone. I've seen it called the resting zone. Okay? Layer of resting cartilage, meaning the cells are just sitting there hanging out. They're not multiplying. They're not getting bigger. They're just sitting there. Okay? The next 2 zones, and now here's the other thing. They teach it as if there's these very well-defined 5 zones. Well, there's always a little overlap going from one zone to the next, so just keep that in mind. The next 2 zones go kind of hand in hand. We have a cell proliferation zone. What do you think's happening there from the name? Cells are proliferating, which also means they're what? Multiplying. So that's our cell hyperplasia. And so what do you think the other zone is going on right next to it with it? First they multiply, then they swell. Okay? So that's our cell hypertrophy zone. So I've already kind of told you what's going on. I just didn't say there's a zone. Okay? So resting zone, zone of proliferation. The chondrocytes are multiplying, lining up in columns. Then they start to swell. The next stage, the next zone, start to enlarge in size. And these are the two zones right here. Cell proliferation, cell hypertrophy, that are responsible for growth of the, at that point, cartilage, but essentially the bone. That interstitial growth is taking place because of those two zones. Okay? Third zone, calcification zone. All right? And when we told you how the bones formed, what happened? The cells multiplied, swelled up, and then what was the next thing that happened? I know you haven't got the chance to study it, so just take a stab at it. The matrix around them calcified. Okay, calcification zone. All right, mineralization of the matrix, calcification of the matrix between these columns of cells takes place. This is temporary, it's going to get broken down, but that's what led to those cells dying, right? And then once they're dead, they got calcified, we know they're going to die. Now we're going to change the calcium, or the calcified matrix into bone tissue, right? So they call this bone deposition zone. We're depositing bone in there now. We're now replacing that dead cartilage with bone. Okay? So the chondrocytes died, leaving channels. We filled it with blood vessels. We dropped in the osteoblasts. We didn't actually drop in osteoblasts, though, right? We dropped in something that became osteoblasts. Fibroblasts that became osteoblasts. And the blood vessels grow in the columns, forming our central canal. The osteoblasts will lay down rings of bone around them, producing our osteons. Okay? The layers of bone that they lay right around a central canal are called what kind of lamellae? Concentric, good. Okay. So this metaphysis, this kind of bleeds over into, it's a little more detail of how the endochondral ossification works. So it'd be a good thing to add into that essay question when you're writing it out. All right. So here's a picture of this. So they're trying to show the 5 stages. They actually only showed 4 because they figured, why show you the resting stage or the reserve stage? There's nothing going on there. So out here, they're resting. They're going to start to proliferate, but they haven't yet. So this zone is starting, the cells are starting to proliferate. So they're starting to, under the hyperplasia, there's more and more of them. This zone is now the hypertrophy zone. They're starting to swell up. They're not really showing them lining up in columns real well, but they do. This stage, the blue, is calcified matrix, calcified cartilage. When that happens, these cells start to die inside there. And then behind it, this is where we've already dumped in the blood vessels. The blood vessels are going to start to grow up in these columns. We drop the fibroblasts that become osteoblasts. We start to lay down bone. Osteoclasts from the stem cells start to break down this blue calcified cartilage so we can replace it with the red bone, osseous tissue. Okay? What do we think? All right? Lots of fun? All right, so here we have an adult's hand and a child's hand. You can probably figure out which is which. But looking here, we have this bone right here. Now, if that's the thumb, and that's the thumb, what bone's this? Radius. It's the radius, okay? And you can see a definitive growth plate there, okay? Bone, cartilage doesn't show up, so it looks like nothing, it looks empty. And then here's the epiphysis of the radius, okay? You can see it down here on the fingers, all right? 1, 2, 3, 4. This is the 4th metacarpal, this is the 4th proximal phalanx, and you can see a space there. This hand is still growing. You can also see the space still because the carpals are developing. Okay? Here's an adult bone. You can see a line. What used to be the plate is now a line. The other ones are a little harder to see. You can see a little bit right there, right through there. So it all depends kind of on the angle of the hand that when they shoot the picture, but that's that growth plate. So they can see what's going on there. Now, back to her question. If somebody has a fracture, maybe it's fractured at an angle through here, or it's fractured right there at the end of the growth plate, they have to reset that, okay? If they can get away with doing it without pinning it, they will. But if you had a fracture somewhat kind of through it, they would need to pin this, at least for a short time, so it reestablishes the bone tissue between them, and then get the pin out of there so the growth can take place normally. Okay? So here's another picture showing you epiphyseal plates, growth plates. Okay? This is really clear. They laid the hand out really flat and got nice images of all those. Okay? So this hand is still developing. This is somebody that hasn't finished growing. Okay? And usually the bigger the space, the more growth left to take place. All right? Any questions on any of that so far? All right. So bone growth and remodeling. Bones grow throughout our whole life. They also remodel themselves during life, okay? All the time. We said it's dynamic tissue. It's always changing. So oftentimes they could be growing to accommodate your brain that's swelling right now. You feel that pressure. All right? Your bone mass density will change. The stronger you get, the more stress you put through the bones, the thicker, stronger your bones will get. The less stress you put through there, the less density, the less strength there'll be in the bones. Okay? So athletes, they're going to have thicker, stronger bones. People that do manual labor, thicker, stronger bones. That's partly why these football players need like training camp. They need to ease into getting hit, you know, running at 20 miles an hour by somebody else running 20 miles an hour. Okay? It's not natural just to walk out and they're able to do that. All right? Now, the weightlifting and all that stuff they do helps. UFC fighters, they're used to getting in the face, getting hit in the face. That's why their bones in their face don't break as easily as ours would. Okay? Some John Jones hit me in the face, I think my face would explode. Okay? But other people, they can kind of take that, shrug it off. All right? But John, he was cheating, so he's a bum. All right. Interstitial growth, we said, was a growth in length, right? Interstitial growth in length. So when we're doing that, we're adding more matrix on the ends of the long bones. This growth is seen at that epiphyseal plate. Okay? All right, so bone growth remodel. Apositional bone growth. That's adding thickness to the bone. So now the bones aren't growing longer, they're growing larger in diameter. Okay, it's a different growth. This takes place more after growth plates have closed, or to accommodate, basically you're stressing the bones and you're making them thicker and stronger that way. So apositional growth, growth in thickness of the bone, growth in width. Adding more matrix to the side surfaces, the lateral surfaces. This is done by the osteoblasts. Okay, the osteoblasts on the inner by the endochondrial, the endochondrium and the perichondrium will start to lay down new bone, making the bone thicker. So it's laying it down on the outside. Okay. While on the inside of the bone, the osteoclasts start to dissolve the bone. So what happens with the bone, and I'll have a picture coming up, the actual thickness of the bone, of what's the compact bone, stays roughly the same, but the diameter gets bigger. Because what it does is, if we lay down new bone on the outside here, making it thicker, we also eat away the old bone. So then when we get out here, the bone still has this amount of thickness. the inside's hollowed out more and more. But when we lay down the new bone, we also lay it down along stress lines and make it thicker. The overall diameter of the bone got bigger, so there's more surface area for attachments of ligaments and tendons and that type of thing, which makes the joints and everything stronger. Okay? But if one of these paces outproduces the other, then we'll have deformities. Okay? If we break down bone faster than we lay down new bone, the bones are going to get brittle. If we lay down more bone and don't dissolve away the old bone, then our bones are going to be really thick and Quasimodo. All right? We're going to add weight to our skeleton, which usually doesn't help us in any way, shape, or form. Okay? So here's kind of what I was trying to verbally give you a picture of. We have this bone here. What kind of bone is that? What would we name it? That's a humerus. Good. So we cut it, cross-section here. Here's what it looks like in an infant. Okay? Here's what it's going to be in an adult. So we lay down new bone out here. We'll say we'll add a thickness to there. And this old part, the osteoclasts, dissolve away. So the diameter got bigger, went from here to here, but you notice the overall thickness, if I measured this distance is only a little bigger. Okay? As we get older, once again, the distance from here to here isn't that much bigger, if much at all, but the overall diameter got bigger because we lay down more bone on the outside and we eat away the old bone. Okay? And we do that along the stress lines to make it stronger. Okay? And that's really important. Like I can't undersell that. For older people, they got to do weight-bearing exercises. They had to do this. They had to come up with stuff. A lot of the rubber band type things that you see, those were developed for astronauts. They send them up in space. What don't we have in space? Gravity. So there's no weight-bearing exercise. So if they're up there long enough in a zero gravity type situation, their bones are going to start to get weaker. And they were worried about their bones fracturing on re-entry. You saw those old movies of the re-entry where they're shaking them around like that. They could get fractures. So they had to come up with stuff for them to do to try to keep some sort of stress through the bone so that their bones stayed strong enough. Okay, yeah?
So, bones are constantly growing, but then what stops it from growing lengthwise? Like, 'cause otherwise,
Well, when the bone catches the cartilage, when there's no more cartilage to undergo hyperplasia and hypertrophy, then it's no more growth. We've changed it to bone and it's done. That's what stops it. So mineral deposition, we've talked about this. This is basically making the osteoid tissue, what's going on there. It's a crystallization process. We take ions, primarily calcium, but we saw there's fluoride, there's magnesium, there's all these things that get put in the bones, but primarily calcium. In the form of what type of calcium? Exactly, calcium phosphate. It's a good thing we didn't have a quiz today. Okay, we deposit the cells there, the osteoblasts, lay down some collagen fibers, and they take that ion, calcium phosphate, and they put it into it. Okay? They put it all around that fiber, and then it crystallizes. Okay? So osteoblasts produce the collagen fibers. The fibers then be encrusted with these minerals, calcium phosphate primarily, and it crystallizes to hydroxyapatite. We can have what's called ectopic ossification, which is abnormal calcification, and that's where this process takes place somewhere that we didn't want it to happen. A common place for that would be like the lungs. Sometimes you can get calcification in the lungs. You can get it in the brain. Lungs are a little more common. Sometimes you put enough stress through muscles or tendons, they'll start to form crystallized calcium carbonate in the bone, in the tendons. Okay, so any place this happens that we didn't want it to happen is called ectopic ossification. Tuberculosis will give you calcification in your lung. Valley fever will give you calcification in your lungs. Valley fever is from fungus out here in the valley. I think it's from bat droppings. So with all the building and stuff, they stir up the sand that this stuff's in, or the dirt, and people breathe it, and they have a reaction to it. Okay, and they get kind of sick, and their symptoms vary. But one of the things they can end up with is some damage to their lungs and this calcification. Well, it's real common out here. If you grew up out here, you're kind of immune to it. If you move out here and you're a transplant, you're not. Okay? So a lot of especially these seniors that winter out here and then they go back home, it wasn't uncommon for them to go back home to, say, Michigan. Doctor's doing a routine thing, does a chest x-ray and sees this calcification. If he doesn't know this guy winters out here, he's worried about that being a tumor. They might start prepping him for all kinds of things. Okay? Just not knowing their history. Okay? Mineral resorption. What cells resorb the minerals in the bone? Break them down so that they freed up to go back in the blood. Osteoclasts. Good. So that's basically we're dissolving the bone, and when we do that, we release the minerals back into the blood. And this happens, like I said, the bones are like second fiddle to the rest of the body for like calcium. Calcium is needed for muscle contraction. It's just one area. The body feels like the muscle contraction is more important. It will take it and use it there. We store the excess in the bone. So if we're not getting excess, we don't put it in the bones. Okay? Performed by the osteoclasts. They use hydrochloric acid to dissolve the ions, to dissolve the calcium. And they use acid phosphatase to digest the collagen fibers. Okay? If you're really bored and you have no like dating life or friends that you go out with on the weekends, you could take a chicken bone, okay? Put it in a jar, pour vinegar all the way up to the top. Vinegar is a what? A weak acid, right? Leave it sit there for a day or two, and that should dissolve the minerals in the bone. You pull that chicken leg out, and what you're going to have is collagen. You should be able to bend that thing all around. Just take my word for it. I hope you have more of a social life than that, but you could do that. Married folks, you'll be doing that this weekend, I'm sure. It'll be the pinnacle. Okay. Other thing. Did I do what? Go back? Sure. No problem. So other things that are related to the bones here. Calcitriol. We mentioned the start of this last unit because we take a cholesterol derivative in the presence of UV light, and the keratinocytes make cholecalciferol. Okay? Cholecalciferol is a precursor to calcitriol. All right? So, this starts in the epidermis, keratinocytes, UV light. Keratinocytes convert cholesterol into cholecalciferol. Okay? Cholecalciferol gets in the blood, blood takes it to the liver turns it into calcidiol. Calcidiol then continues in the bloodstream, goes to the kidneys will turn it into calcitriol. Okay? Calcitriol is a hormone-like substance. Okay? Its function is to increase blood calcium levels. Emphasis on blood calcium levels. Okay? So, what are some ways that you can increase blood calcium levels? What are some ways you could increase the amount of money you have? Don't buy things. Stop spending. Okay? So that would equate in the body to don't lose it in the urine. Okay? Don't take the calcium out of the blood at the kidney and lose it in the urine. How else could you have more money? You could make more money, right? All right? So we could take more calcium out of the foods we eat. Instead of absorbing 10% of it, let's absorb 25% of it or 50% of it. Okay? And then lastly, what calcitriol will do is it'll break into savings. Savings, where did we save calcium? In the bone. Okay? So it's going to open up the piggy bank, take the calcium out of the bones and put it in the blood. All three of those would put more calcium in the blood. That's what calcitriol does. Stimulates intestinal absorption of calcium, phosphorus, and magnesium. Weakly promotes urinary reabsorption of calcium, meaning we don't lose it in the urine. It increases osteoclast activity, which breaks down the bones, freeing up the calcium to be put back in the blood. All that makes sense? All right. So you can save the money, get it out of savings, or make more money. Okay? It was interesting. My first wife never understood the save the money. You ladies get that, right? No? I think she literally told me at one point, you just need to make more money. Cool. I had never thought of that. All right, so this, we don't really need to look at this. This is showing us our cholesterol derivative. It starts off as this. The chemistry, oh, I hate chemistry, changes the molecular shape of it, but it still has this kind of cholesterol backbone. It's not important. Chemistry gives me, like, I think I go into seizures. Okay. Calcitonin is another hormone. Calcitonin is produced by the thyroid gland, by special cells in the thyroid gland called calcitonin-producing cells, which we call C cells for short. Okay. That's the cool thing a little bit about anatomy. A lot of the things they named kind of fit. Instead of being Khrushchev cells that produce calcitonin, some guy that put his name on it. So calcitonin cells of the thyroid produce calcitonin. Calcitonin is secreted when blood calcium concentrations are too high. So, being the honors class that you guys are, if calcitonin is produced because blood calcium levels are too high, it's probably going to do what to blood calcium levels? Lower them. It's amazing. Look at this. You guys are like rock stars. All right, so it functions to reduce the blood calcium levels, and so what would it do to do that? It would reduce osteoclast activity, right? Because it's breaking down the bone, putting it in the blood. They're going to say, no, stop that. What's it going to do to osteoblasts? It's going to say, hey, fellas, let's get to work. Let's take this extra calcium and put it in the bone. Okay? Increase the number and activity of the osteoblasts. Interestingly enough, calcitonin is a hormone that's very active and very prevalent for children, but adults don't produce much of it. Okay? And essentially the deficiency of it is really not even considered a disease. However, if you had an older woman and she was osteoporotic, giving her calcitonin or a synthetic calcitonin might give her some results, right? Some benefit. That's what drug companies do. They figure out how things work, what's in there, what's it doing, and then they try to figure out a way to mimic that. And they patent it, and then they make billions of dollars. All right? So, you guys go out there, come up with something like that, make billions, kick me 10%, that's my usual customary fee, and we'll be good. All right? And I don't have to come here each morning. It'd be awesome. All right? Another hormone, parathyroid hormone, secreted by parathyroid glands, works synergistically with calcitriol. Okay? What's synergistically mean? Kind of works with it. Okay? So it's going to do all the same things. Parathyroid hormone actually leads to when parathyroid hormone's released, it actually tells the kidneys to turn calcidiol into calcitriol. Okay? So they go hand in hand. So it's going to do all the same things. So if you remember what calcitriol does, parathyroid hormone is going to do the same thing. It's going to function to increase blood calcium levels. Okay? It's secreted when blood calcium levels are too low because it wants to increase them. So what's it going to do? Stimulate osteoclast multiplication and activity, promote calcium reabsorption by the kidneys, promote calcitriol synthesis by the kidneys. As you can see, the kidneys are pretty damn important. And it's going to inhibit the osteoblasts. Okay? All right. Doing okay? All right, skip that. So basically all it's saying, this slide's just saying the three hormones that affect calcium concentrations the most in the body: calcitriol, parathyroid hormone, and calcitonin. We don't care. Well, the net effect of calcitriol is to what? Increase calcium in the bone, increase calcium in the blood. Increase calcium in the blood, okay? Healing of fractures. Okay, when a bone breaks, we form a hematoma. Blood leaks into the area. That's what a hematoma is. So formation of a hematoma. Ooh, this is small print. The fracture severs blood vessels in the periosteum and in the bone, and blood leaks in there and starts to clot. Some of the blood cells, I thought I was going to talk about some of the blood cells in that area actually kind of die, but we'll get rid of them and replace them. And what starts to fill in the area initially is fibrocartilage, and we call this a soft callus. And it does this within a few days. And that's what's trying to kind of initially reattach the bones, is this soft callus. Capillaries are going to grow into that area. They're going to fill it in with collagen fibers. It's also going to fill it in with a little more of that fibrocartilage. Collagen's more important because it belongs there, right? We're going to eventually, what? Calcify that collagen fiber. And the bones are reconnected. When we get collagen from the healthy bone to collagen to the healthy bone, spanning that gap, we've actually reattached the bone. Then if we ossify that, we're in good shape. Okay? A bony callus within a week is present. So we replace the soft callus. We get rid of that fibrocartilage that was there initially. We replace it with actual bone tissue, which is osteoblasts laying down bone in that area to form kind of a spongy bone attachment. Okay? We're also going to start the process of that endochondral ossification again. We're going to start to lay down layers of bone around the blood vessels that are now spanning that gap. And for months after that, we're going to have remodeling. Okay? Compact bones laid down around stressors. Okay? Stressors being that mechanical stress. The layers of bone, the collagen fibers in those lamellae get laid down in different orientations along what's going to provide the best support. So we start off with a soft callus, which is fibrocartilage. We replace it with a bony callus, which is osteoid tissue, primarily collagen fibers in a spongy bone arrangement, and then we replace it with the actual lamellae, the osteons. Okay? Now, anybody that's had a fracture, there's a certain point where you're not really cleared to do everything you want to do, but they do want you putting a little stress through the bone, and that's why. You're usually in that 3 or 4 week area, and they want the bone to be laying down the collagen fibers along the stress lines. They don't want you to re-break it, but they want you to stress it just a little bit. Well, then it's not going to heal strong, okay? And usually they don't want it. They don't want, when they take the cast off, you're going to be a little weak muscle-wise, but they don't want the bone to be weak. So they want a little stress through that. So they'll usually start you off with a little bit of weight-bearing exercise, might be rubber bands, something like that. But all in all, this all happens pretty quickly. Bones heal 4 to 6 weeks. You have a fracture, it's usually 4 to 6 weeks, unless it's crazy through an epiphyseal growth plate or some sort of spiral fracture. Those don't heal real well. But a simple fracture, 4 to 6 weeks. Okay. Speaking of fractures, we'll go through some types of fractures. We have what's called a closed or open fracture. They used to be called simple or compound. Okay. So a Open or compound fracture means their bone's broken and a portion of that bone is protruding through the skin. Okay? And that's more problematic because that opens you up to infection, okay, which can be bad. All right? If the skin's intact, then there's less worry about infection. You more set the bone, immobilize it, and it should heal normally. A linear fracture, we think mostly of bones, if this was a bone being broken through this way, okay? A linear fracture means the fracture is going to be something like this, along its long axis, okay? Bone broken along its long axis. A Lisfranc fracture, these are starting to become common in football players, and it's usually a season ender. It's a fracture and dislocation of the tarsal metatarsal joint. Okay, so we have to think in our minds, tarsal metatarsal. So it's a fracture dislocation in the bottom of our foot, right? The sole of our foot is the metatarsal. The tarsals are the bones that include the talus, the calcaneus, the cuneiforms, the cuboid, navicular. Okay, so we break something in there and we dislocate one. Dislocations can be problematic. Okay, to reset those, especially in the foot because you have so many arches. You have an arch on the bottom of your foot. You have an arch across underneath the balls of your toes. So to set that foot back right is also difficult. A green stick fracture is a bone bent with a partial fracture. Now, a bent bone. Who would be susceptible to a bent bone? Children, because their bones haven't totally hardened yet. Okay? So it saves them from breaking things a little bit because they're a little more flexibility. But a green stick fracture, you see a partial break, almost like a tear in the bone. Okay? And it can look a little bit like this. Now, there's a little bit, this is more of a linear fracture, but there's the fracture and we have a little bend in the ulna. Okay? Green stick fractures are common in kids, and these are the things that can happen to kids when parents jerk them around, grab them by their arm or their wrist and do this and that. And you end up in the hospital more than a couple times with a green stick fracture, and Child Protective Services is going to talk to you about what the hell's going on. Okay, whether anything's going on or not, they're going to want to know, why is this happening? Okay. A comminuted fracture, bone broken into 3 or more pieces. All right, so here we have a knee, and as you can see here, they're going to need all the king's horses and all the king's men to put Humpty Dumpty back together again. We got a broken bone here, 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 and obviously the end here. So that's going to be a bigger deal. To set this break right here, you usually just have to traction it and it'll almost go back together the way it's supposed to. There's no simply tractioning that. They have to go in and they have to pin those all back, wire them the way they're supposed to be, get everything start growing, and then pull the pins out. Okay. Impacted fracture, bone driven into the marrow cavity of another. So here is the best example I could find on something we could actually see. Here we have the ulna. It's broken, and part of the ulna is jammed into the medullary cavity of the other part of the ulna. Okay, so that can cause more damage. They're still going to try to traction that out and reset it, but it's also broke on a funny angle, so that makes it problematic. Spiral fractures. Fracture spirals around the long axis. These are very difficult to heal. They're also really new injuries. These tend to happen in football players who are both fast and big. So they're running, they're on turf, they plant their foot, they spin, and you get that weight moving in a circular manner. And it's so a spiral fracture is like taking somebody's tibia, and you don't break it like this. It's almost like you're wringing out a rag. There was enough twisting force that it broke that way. So setting that bad boy is going to be a problem. Okay, and so it requires lots of force. Okay, and usually you got to be big and fast and all that to do that. Kind of like myself. So here we got a tibia, and something happened. Now, they probably had this ankle all taped up too, so that restricted some of the movement here, and the force was put through this portion of the tibia. And you can see how that's going to be difficult to set back just right. And anything that's difficult to set requires longer healing process. Compression fractures happen oftentimes in the vertebral bodies. They get smashed. Okay, you take a senior citizen, the bones are a little bit thin, and they fall. They fall on their butt. Okay, and just that compression of hitting their butt causes one of their vertebral bodies to basically disintegrate. It looks a little bit like this. All right, this one looks normal. This one looks normal. This one got smashed. The thing with this is that's considered a stable fracture. They don't oftentimes even do anything for it. Okay? So they can do that, break that, and they may not even know. All right? Where they can come into problems is between the vertebrae, we're supposed to have a space, right? What's that space where the nerves come out? It's called the intervertebral foramen. So I can see one here. I see a little bit of problem in there. It's a little bit foggy, so it's not as clean and clear as it should be. But the intervertebral foramen here, I can't see it. So there's a chance that the nerves coming out that way are going to have some sort of irritation. So they're going to maybe have some nerve pain that they would be aware of at that point. A Colles fracture is a fracture of the distal end of the radius in the ulna. This one can happen sometimes when you fall, okay? And you don't damage the carpals, but you damage the distal end of the radius in the ulna. Both of them are broken. Once again, now you're setting two bones. So that's a little bit of a problem right there. I would not be surprised, I don't know for sure, but I wouldn't be surprised if this isn't what happened to David Johnson and why that's his injury is like a big deal. Getting that back, and then when they get the cast off, getting the strength back that he can hold onto a ball well enough. Okay. Pott's fracture, same thing, two small bones of the leg though. Fracture the distal tibia and fibula. So think of this one, Pott's fracture. What helps me is if you're jogging, you're not paying attention, you got your music on, and you step, it's like early morning, you can't see that well, and you step into a pothole. Think of that, that'd hurt. Just thinking of that hurts. So this is not the best picture, but you can see this is the ankle down here, fibula. We've got to break through the tibia, we got to break through the fibula. Okay. All right, so we got a couple videos here to show you. They're kind of cool. I don't know if we got time. Give you a breakdown because we're ready for a test on Tuesday. I think there's an essay question on the test. I don't know if you know what it's going to be. I'll break this down for you as quick as I can. I'll put the video on. If you want to see it, you can watch it. Let's